So a lot of people define dissociation based on symptomology when really it's really a way that you encode memory. Like you're storing memory into the body. So you have like flashbulb memories, you have like your stereotypical like you both are looking at me right now, and then like it's going into your working memory. Maybe you'll throw it out later. You won't remember this moment potentially, or maybe you'll hold on to it forever. Who's to say? Like, but essentially when you have dissociation, it's imagine kind of like a grate in front of you of your perception, and like the picture of my face, for instance, that you're looking at goes through, and then it feels like it's like a million little pieces. Like a million is probably like an understated because of the brain, right? Like, but either or, essentially, like you're not getting the snapshot. Like we don't record in video. A lot of people are like, oh, I see video. Like, no, it's like you have snaps. But then when your average snapshots of your memory actually like goes through a grate, all of a sudden it's like, okay, well the sound might actually store somewhere else than where the picture and image stores, and then like the feelings that you somatically held.
Our goal in creating Finding New Waters is to provide a resource for families to help navigate the complexities of supporting a loved one through the struggles with substance use and mental health. When we find ourselves in a crisis due to one of these issues, most people have no idea where to turn. We hope to shed some light into what is often the darkest hour for many families. So today on Finding New Waters, we have our guest Erin Lewis joining us today. I'm also joined by Dr. Harold Hong, the medical director at New Waters Recovery, and as we were discussing, many other things as well. Erin Lewis, MS, LCMHC, NARM, and master therapist, is a somatic psychotherapist specializing in dissociative disorders and trauma treatment. Erin began her career in healthcare working in nursing homes, primarily on the dementia care unit and rehabilitation unit, as a certified nursing assistant. This is where she became passionate about mental health care and later began working in a residential transitional group home for individuals with acute psychotic disorders for several years. Erin became passionate about the trauma treatment clients were receiving, which resulted in her choosing a specialty in trauma treatment. Upon having worked in different levels of care, Erin became intrigued with clients who reported experiencing dissociation. Erin then decided to receive training and specialized in dissociative disorders, primarily focused on dissociative identity disorder, or DID. Erin is the co-owner of NC Cutting Edge Counseling, an advanced trauma treatment outpatient group practice that bridges the gap between research and clinicians to give individuals with trauma the most effective treatment to date. Erin lives with DID and runs community groups for people with DID. She is involved with DID research and educates, trains, and consults with clinicians on how to treat dissociative disorders. Erin lives with her husband and 3 dogs in North Carolina, where she enjoys connecting to God through Bible study, running, comedy, nature, dog walks, hiking, and music. I love it. What kind of music do you like, Erin?
So obviously Eminem is the greatest rapper of all time. I'll just go on record saying that. Mm-hmm. But also, I mean, the rap genre.
Okay.
Period.
Cool.
It's just like so, like acid rap. You go back to like throwback Tupac and Biggie. I like them both. All of it. Halsey's good too.
Okay. Cool. You know. I love that. Love that. So I know we read a little bit about your background, but maybe we could start with you just shedding a little bit more color, right? Like, why did you become a therapist? Why the interest, right?
Yeah, so I actually was one of those people that was like, I hate therapists, I hate therapy, I hate the whole, like, burn it to the ground kind of a person. Right. And then I think it was because being in the nursing home specifically, I would see all of these really, like, problematic clients or patients, really residents of the nursing home. And it wasn't that they were problematic. They were just weren't receiving the right treatment, and they were really being overlooked. I mean, from bipolar to schizophrenia to PTSD. And I was just like, there has to be a better way for, like, especially at the end of life, towards the end of life, or, you know, even if you've had a stroke and now you have to live in one of these facilities to help, I felt like there had to be some, like, what is missing? And then, like, I looked at the staff roster, because then I was actually going to go into an administrator type of position. I was looking into going into that, like running not hospitals necessarily, but more nursing homes were my focus. And then I was like, where are the staff therapists? Fun fact, nowhere. Like, there's occupational therapists. And I was like, that's the wrong kind of therapist, it felt like. So I was like, okay, well, what's the gap here? Like, what's missing? And then when I went and started working at as a case manager, or like called a care coordinator at that place. It's a case manager though. Position at a group home that was specific to acute psychosis. And it was really like the testing ground if you're going to go in the state hospital for an extended period of time, many years, or if you're going to be able to ever go back out in the community. We were that testing ground. So it was like very heightenedly acute. And I was like, okay, crisis work is all right. You know, like it was just like that adrenaline. And then I was like, oh, I didn't realize at the time that was my own trauma. Things that like, I love being in crisis, not me personally, but like helping people through crisis. I have this calm that starts to like, oh, things feel right, which is the opposite I learned of like a lot of the, you know, someone's like setting the house on fire, somebody's throwing chairs. And I'm like, all right, well, like, let's just figure it out. And I was like, I think that I want to be a trauma therapist. And so then, you know, many years later after the schooling, I'm actually going back to school in 2 weeks for my PhD.
Oh,
that's
good
when
for
I will
you.
start.
Wow.
Cool. Specializing in trauma, which is kind of silly. I
Why
was
is
like,
that silly?
because it's like I already specialize in it, and I feel like I'm cheating. I don't know. I was like, maybe I should do addictions or something. I don't, like, mix it up a little. So that's really how I got into like the therapy world. Before that, I was also like pre-med. I was very much like biochemistry nerd. And then I was like, oh, I think I want to sit and talk to people, actually. You know, like also organic chemistry is the worst. Hats off to you.
Those are tough days, dark days.
Dark days.
Actually, there's trauma there. Actually, we could probably talk about that, and probably some dissociation, certainly.
I believe it. It's like, what are these covalent bonds? And I was like, oh no.
Yeah.
Yeah. Oh goodness. So trauma. So, you know, so one thing that comes up for me is dissociative disorders is, you know, maybe even just starting with like, what is dissociation, right? Like, what does that even look like? Where does it come about?
Right. So a lot of people define dissociation based on symptomology when really it's really a way that you encode memory. Like, you're storing memory into the body. So you have like flashbulb memories, you have like your stereotypical, like, you both are looking at me right now, and then like it's going into your working memory. Maybe you'll throw it out later. You won't remember this moment potentially, or maybe you'll hold on to it forever. Who's to say? Like, but essentially when you have dissociation, it's, imagine kind of like a grate in front of you of your perception. And like the picture of my face, for instance, that you're looking at goes through, and then it feels like it's like a million little pieces. Like a million is probably like an understated because of the brain, right? Like, but either or, essentially, like, you're not getting the snapshot. Like, we don't record in video. A lot of people are like, oh, I see video. Like, no. It's like you have snaps. But then when your average snapshots of your memory actually like goes through a grate, all of a sudden it's like, okay, well, the sound might actually store somewhere else than where the picture and image stores. And then like the feelings that you somatically held, or like your body feelings can store somewhere else. And then like, so then you have all of these fragmentations. So let's say you went through like a trauma. I don't know. I clap my hands. This is traumatic for some reason right now. Right. So there's a part, like if we're dissociated, right? Like, so a part is going to hold that like sound of clapping. Then there's going to be another part that's going to hold my voice likely and whatever I am actually saying. And then there's another part that's holding that like body memory. Like that's as simple as I can break it down. Essentially, it's the way that you store memory, and it happens commonly in PTSD. It actually happens commonly in every disorder there is, if honestly. So when we look at like even major depression, like severe major depression, where it's like, I can't get out of bed, every day is the same day over and over again. What month is it? Like there's a level of dissociation there. Now, when you look at it from like more of a trauma lens, there's different types of dissociation. So let's say I was handcuffed to this chair and I'm dissociating or something, right? Like potentially later on when I'm processing with my therapist or something, my actual left hand could go numb completely. Not my whole entire body necessarily. That could happen as well, right? Like, so then it's like very selective, like dissociation of like, oh, now my hand is numb. I can't feel anything.
Interesting.
So there's so many different types of dissociation. But it's like, so depersonalization, derealization, for instance, an episode of that happens to 52% of the United States population at least once. So it's very common.
So is that a type of dissociating? Depersonalizing, derealizing, those are specific types
Yes.
of dissociation?
Definite. It's definite over time. So it's kind of like, also since I had my start of my career in psychosis, a lot of times I'll be like, oh, it's kind of like that. But so it's not like psychosis, just to say, but like I'm making this comparison of like, so essentially like once you have certain delusions and you have like a psychotic break, let's say, and let's say you think you're God or something, delusions of grandeur that you're having, then you come back to reality, you're on medication or whatever, you stop taking your meds or something, then you go back to that same delusion usually. It's along the same lines. So dissociation, sometimes people dissociate from their body specifically, or even their identity, where it's just like, am I a person? Like what's happening? Sometimes it's the environment though, right? Like it's like, oh, this isn't real, like, or maybe it is, like, and everything kind of feels like farther away. So if you think of like shock, this is your body is taking in too much at one time to really like take it in.
Yeah.
So it has to store in other places. So those are unprocessed memories. Yeah, I love memory. I can go into memory forever. But
I love that.
Yeah. Like for people out there who aren't professionals, what are some signs that like a loved one is dissociating?
so it can actually be very difficult to catch.
Okay.
You might not know it, or it can be profound. Everything's on a spectrum. So slight dissociation, I mean, even you driving, like let's say on a long road trip for 100 miles, you don't remember 60 of those miles because you're thinking about spaghetti. Now I'm thinking about spaghetti, but or whatever food that like you're thinking about, or daydream about like wherever you're going to be, your destination. Now, like you've not encoded that entire strip of land, which is 60 miles, right? Like that's so like it can also be kind of like daydreaming. So it's just like they're kind of not there, or they can like have this stare. It's like the 1,000-mile stare. Where it's just like, what? Sometimes if you talk to them as well, like this is more on the profound end. Sometimes when you talk to them, they take a while to respond. So it can be like, hey, how are you? And there's like, they're really like, it's taking them some time to get that cognitive awareness because they're somewhere else. So it can look like that. How else can it look? I treat like a lot of the severe side of dissociation. So what I'm thinking is sometimes people are so afraid and terrified and frightened, just like talking in a room with somebody, that they're almost nonverbal or completely nonverbal. That can be that they're dissociating. It's just too much for them. They're too afraid.
Right.
It can look like all of those things. Sometimes it looks like, because like I have DID, right? So I dissociate fairly often all the time, right? Like, so my husband, for instance, he'll be like, oh yeah, we're going to a party Saturday. I'm like, cool. And then it'll be like 30 minutes later, and I'll be like, hey, Saturday, I was thinking that we would like go to this place or do this thing. And he's like, so we're going to that party. He's like, I just let it, you know. And I'll be like, right. So I like, if you're planning something, you got to write it down.
Okay.
Kind of a thing. But that's like a common one. It's more than mindlessness, though. So if you think of mindfulness, the opposite mindlessness is like you leave cabinets open or something.
Right.
That's kind of like your mind is somewhere else, but that's not necessarily dissociation, just to like bridge that gap a bit.
Yeah.
But yeah, those are some ways that.
Because there's being distracted, right? So if my wife is talking to me about errands for the weekend, but I'm thinking about like being on call for the weekend, I might just miss a detail.
Yeah.
That's distraction, not dissociation.
Yes. Dissociation's like, oh, I'm paying attention to you. I'm like, yes, I'm in it with you. And then all of a sudden it's like, so it like a lot of times with dissociative identity disorder specifically, or like more even OSDD on the sides of dissociation that's more profound, it's like they're listening. They're not necessarily even distracted by anything. They're listening and it's just gone. And a lot of times they don't know that it's gone until you start doing like these timelines, and it's like, oh, they think that they remember everything, and they're like, yeah. Like they're covering a lot.
Yeah.
And they might not even know that they are covering, because this is really a disorder of hiding.
Right.
So then you do these timelines, and it's like, oh yeah, I don't remember second grade or third grade or fourth grade. And all of a sudden it's like, oh, you don't remember 10 years of your life, you know, and or however long, right? Like it could be even more or less. But yeah, distraction is different than dissociation for sure.
So I'm wondering, what's happening like neurologically there? Like, is there something that's kind of going offline, or like any thoughts on that?
Oh yeah, I am a neuro nerd. Okay.
So let's do that.
So we find a couple of interesting things in a brain with DID. We don't know everything that's happening. It is widely being researched, and it has been for the last 10 years or so. However, so there's this hypothalamic pituitary adrenal axis, HPA axis, right? Like in the brain that upticks with trauma specifically. But think of it like almost like a gear that's turning for everybody. It's just like, okay, now you've had some trauma and it's going, and it's like, okay, well now you have a dissociation. And it's just like your amygdala is firing, your hippocampus is firing, your hippocampus is overgeneralizing things. Your amygdala is like, everything is a threat because your hippocampus has overgeneralized it. The amygdala, think of that as like your threat response a little bit. It's just like your little alarm bells. And so what we see over time, what that creates these neurological differences in the brain is that from PTSD to DID, because there's a trauma spectrum, what we see in people with DID is they actually have larger matter, white track matters in their brain than gray. So you have white matter and gray matter. There is a reduced level of gray matter in the brain, increased white matter. What is really interesting, I'm really into this biomarker right now. It's called tumor necrosis factor alpha, and it's actually reduced in people with DID, which is like weird because it's increased with people with PTSD. A lot of the research is showing. So it's like, what? So I'm very interested in that specific because there's really a lot of interesting PTSD research being done.
And what is that responsible for, that particular biomarker?
Yeah, so it's involved in everything, in my opinion. There's so many things it's involved with. But there's inflammation. It's an inflammatory marker.
Okay.
But it's reduced, which is interesting because trauma increases it over time. And in North America, even more interestingly, because I treat in multiple different countries, if I can treat there, right? In Germany, I can't. They have certain licenses that I don't have, but like the UK is different. Anyways, but if you look across the globe, PTSD is kind of joked to be an Americanized disorder because like there are such high rates here versus anywhere else in the entire world. So there's lots of theories behind that. We don't 100% know, but there are some theories. Anyway, so like with the dissociation, specifically, I think what is super interesting from a global level is when I read it, I was like, that can't be right. I was just like, I disagree with this statement. And then I had to do a lot of digging, and I was like, oh, I'm wrong. Like the research, I'm always going to like go to the research. So essentially people in North America with DID, they have more psychosomatic symptoms. So like body symptoms. So these are like pseudo seizures.
Okay.
You can have parts that have parts, personalities. I think of them as neural networks myself, but whatever you want to call them. Some can have diabetes. They actually process drugs differently which makes it incredibly, you could likely speak better to this, hard to treat medically. It's not like it's a serotonin reuptake situation.
Right.
It just depends. Your cells are moving dependent on the neurological network that is online, essentially, or whatever part is fronting, whatever language you would like to use.
Yeah.
Yeah, I mean, trauma, it changes not just how we think and how we feel, but our bodies,
Yeah.
right? Like our brains. Like there was, in just a couple months ago, the American Journal of Psychiatry had this wild study where they looked at brain scans of different races and different mixtures of trauma in their history. And the earth-shaking finding of this was that the brain volumes for the part of your brain that controls like emotion regulation, planning, executive function, trauma makes that smaller, right? And also the other parts that are involved in emotion, like the amygdala, like all those volumes get smaller. And races and ethnicities that are more likely to be traumatized have smaller brain volumes. But a white person who was as stressed as a black person, they have like similar brain volumes in those pieces. And so trauma, it physically affects how our brains are. And it's striking. And then when you have trauma and stress, your cortisol levels go up, and that suppresses inflammation by suppressing your immune system. And we know people who have high trauma scores are more likely to get cancer, because we know that cancer is in some ways a disorder of your body not detecting and eliminating mutated cells correctly. So these are profound things, and I think only now is the science and our awareness of just our everyday living coming to make sense and connect with each other. But like for there's so much that our listeners can benefit from by understanding like their histories and their bodies and their relationships more deeply, and I get really excited about coming to work because this is where it all connects, right? So I know that our patients, our clients they use alcohol to deal with pain, and like to disconnect from stresses in life. And there's a lot of parallels between that and other stories I've heard about children being abused, and they create like this magical world in their mind. And when their parent is out of control, and the abuse begins, their mind goes to this magical place, and they don't feel or remember what happens. And so I see a lot of parallels. But you being a therapist who specializes in this world, I would just love to see if you see something like this, and if so, like what's going on.
I'm like, that is dissociation.
Yeah.
Like, I got all smiley because I was like, oh yeah, like that that other world, or it's kind of like, this isn't happening. Like it's not just denial as much as it's profound, right? Like it's not happening right now. Dad is throwing something across the room. It's like, well, no, that's not happening. Like, look at me and this family that I'm sitting, and you created a whole different family.
Right.
It could be, we see this especially in foster care systems, where they have like this imaginary family that really loves them and cares about them. And it's really helpful in terms of coping, because sometimes it's like a kid is sometimes in just a really horrible situation. They don't have the resources to get out. They don't have usually, unless they're like child stars, right? Like they don't have their own homes and jobs, and they can't set those boundaries. So that dissociative factor is so helpful. It just becomes too leaned on, And all of a sudden it becomes not helpful in adulthood.
Right.
Because then it's also hard from a somatic sense I always ask this question to my clients of, when did you know it was over? Like, when did you know the abuse was over? Whatever it is. When did you know it was over? And a lot of times they're like, what are you talking about? And I'm like, I mean, you're sitting here in front of me right now, because there's so much trauma memories that are unprocessed by that point that they get to you as an adult, that it's just like they're really in this heightened state, like on edge.
So it's never ended, right?
Yeah.
Interesting.
And then once they say it out loud, like, oh, I guess I knew, because then asking them that, it's kind of like a tricksy way of trying to break down those amnestic barriers in the brain between like their memories, essentially, or those neural networks that they've created, these amnestic barriers, which is just like the barrier between like this horrible information and your life experience and where you are today. So then you're asking them to reflect. Anytime you're asking reflective questions, they actually have to go back into their memories and think about it. A lot of times you'll see them answer very quickly, and they don't think about it at all because they don't want to. So if you're like, oh, just take well, it's not done. Okay, well, just take a second. And like, would that be okay to sit with just for a minute, this question? When did you know it was over? And then a lot of times once they can track it back, they might be like, oh, I guess when I went to college. And now all of a sudden they're remembering that they went to college. Like, and that's with the more profound dissociation. Like PTSD dissociation is more like they know they went to college. They just might not. I think in PTSD, I see a lot of times the emotions removed quite a bit, unless they're like very volatile because they've been triggered. But with dissociative disorder, sometimes it's like, yeah, I got this 4-year degree, and it's like, who got it? Like someone in here did. And it's that level of disconnect. Really, it's the narrative phobia is what I would say in that client as well that you were talking about scenario. The narrative phobia, I think, is really understated clinically.
Interesting. So I'm thinking as you're talking, so I've done some EMDR. I don't really practice currently, but so as you're talking, I'm seeing through that lens. The question I guess I'm getting to is like, how do we treat this, right? Or how do you treat this? But I guess I'll lead with, do you use EMDR?
So in my practice, we do have, like my business partner does EMDR. For instance, I personally do not treat with EMDR because I can't my saccades are off in my eyes actually. And it would probably make me suicidal actually if I were ever to have EMDR therapy. So it's hard, like, because I got some neurological testing done, because a part of having DID is like, I don't have this. This is a bunch of lies. So you want to disprove it no matter what. So I went through all of this like neurological testing, and then they were like, oh, don't get EMDR. And I was like, oh, why not? Because I was like, seems like an all right, it's a trauma modality. And she said my saccades were off and that I wouldn't be able to process the trauma that was coming up. It would just flood me essentially.
Interesting. Okay.
And I think that's why there's potentially like these hit or misses with EMDR. Sometimes it's like the best thing you've ever had. With clients, it's just like breakthrough. Yeah. So much peace. And then other times they leave and they have a suicide attempt. And it's like, I am not an EMDR clinician. I don't think there's anything wrong with it. I think that I don't know how you would test the saccades or whatever, right? Like in the eyes, but how I treat all trauma, it really is through like an attachment lens, first of all. I'm NARM master trained. So that's the neuroaffective relational model of therapy, very attachment oriented. And IFS, I think IFS is gold. And
what's IFS for people who don't know?
Oh yeah, my bad. Internal family systems model. It's created by Dick Swartz, and I think when I look at DID, there are so many different neural networks. It's like sometimes CBT works for people, right? Like I think with trauma, there's a lot of like CBT is very top down processing, brain then to the body. I think you also have to do the body to the brain, which is that somatic end. So NARM meets in the middle, like doing both of those, but People with DID usually have shock trauma, which I think is better treated by an SEP. I'm not an SEP, somatic experiencing practitioner. But I think people with DID have to be treated with several different modalities because, like, DBT, great, not great as standalone, though, like dialectical behavioral therapy. So a lot of times I'll send in with DID, a lot of times, and a lot of other dissociative disorders like OSDD, there are comorbid eating disorders or substance use. And it's like, well, you can't be a specialist in everything. So if they have substance use, a lot of times I'll send them out to like co-treat, and like whoever specializes in substance use, I'll send them to a clinician for substance use. I'll work on the trauma piece or in eating, the eating disorder side of things. I send people out for that all the time. And then we treat them at the same time because you can't just treat one or the other. Treat the trauma, the eating disorder is going to increase. Treat the eating disorder. It's just like, then you're not treating the trauma, and then it's like the issue is still there. So I essentially, it depends on like what the client is wanting, but usually my go-to is internal family systems, neuroaffective relational model, and then other kind of SE, somatic experiencing practices.
And how do those things help your clients move towards recovery?
Right. So defining recovery is probably the first step of that. What I'm really sitting with is like a lot of practitioners are like, full integration, fusion, that's where we're going with DID. And it's like, I mean, would you tell someone with anxiety, like, this is what I planned for you in your life? And it's consent first. So essentially DBT, dialectical behavioral therapy, I send people to those groups all the time because like they do need skills, actual taught skills. A lot of times they come from families that it's like they were taught alcoholism, they were taught self-abuse, or they were taught to abuse others, and like that's how you cope. And it's like, okay, well, here are these very concrete skills that you can do, like dunking your head in ice water or something when it starts to build up. So that helps in terms of actually being able, like there's a learning part of this for sure. Like there's a learning curve of, wait, not everybody like drinks at 9 a.m. Oh, wait, not everybody starves themselves for 15 days at a time. Like there's a lot of that kind of distance. So they do need to learn the skills first to even be able to process the trauma. That helps with the stabilization phase. You always have to make sure someone's stable before you just go diving into their deepest well of trauma. Yeah. Or else it'll go poorly.
Absolutely.
And there's like a 70%, the statistic from the DSM is 70% of folks with DID actually have a serious suicide attempt. So it's like, it's very high. So you got to go slow. Treatment, slower is better, and then half of that speed, and then like 5 times slower than whatever half of that speed is, and that's the speed you need to go with somebody who has DID. Dissociative disorders in general, like OSDD as well. So yeah, the DBT helps with the skills. The IFS helps with defining the neurological networks or the parts, or right, like so IFS language is parts. Everyone has parts, whether you have a boatload of trauma or not, you have parts. Like, you talk to your mom in a different voice than you talk to your best friend, then you talk to your significant other, then you talk to your boss. Like all these different parts coming into play. So the research on parts are really interesting, this type of therapy, because it provides distance that you can actually start having compassion again. It's like too much to have compassion for the self, right? Because now you've been built on a shame model. So it's like, okay, well, this part of me, oh yeah, that little kid part, well, that's a rough go. And then you can have some startings of that. I think it's great for that. It makes compassion less daunting, because sometimes compassion feels like horrible to someone who has DID if they really, really believe that they are bad inherently. Even with PTSD, trauma in general. So the IFS, I don't agree completely with any theoretical model. Actually, I I side with some more than the others. So then I think where IFS, I leave off, I focus on more of the immediate moment with NARM of like, well, let's talk about quality of life. Like, what are you wanting for yourself? What does your recovery look like? What does your treatment look like? What are your goals here? Sometimes it's like, I want to get a job, or I want to talk to people, or whatever or I just don't want to have flashbacks every day. Like, okay, well, like, let's start working towards those steps of whatever this looks like for you. Some people are like, I want fusion, if they've been on the internet a lot, like I want fusion.
Like TikTok. Oh, come on.
TikTok.
Gotta love TikTok.
I love TikTok for like dog videos, like those silly, like those parkour videos where it's like they're jumping over water and then they land on something.
I've had a lot of conversations with patients saying, I saw this on TikTok. I want to get checked out for it. So, I mean, there's a lot of unusual perspectives out there, but it's getting people out of their chairs and into clinics, face-to-face with new providers. So I think if people can handle the curveball of redirecting the TikTok momentum, it could actually be really, really great. But I agree, it's not like the usual best first step for people to take.
Yeah.
Maybe you don't want to just necessarily take your mental health advice from there, right?
Yeah. Talk to a professional.
I think my reaction was like, oh, TikTok is because the DID community specifically, I steer people away completely from Reddit, completely from TikTok. So there is about a 12 to 24% rate of malingering with DID. It's being very fetishized right now. So at higher levels of care, you're looking more around 20% or the higher ends.
Wow.
And I think a lot of times, like, I have a lot of compassion for it. It does make me angry on one end, right? Like, and like, sure. But like, if we take a compassion lens, a lot of times people have been neglected. And now it's like, oh, look at this, look at me.
Totally.
Meet this part, and like.
It's true, because there are a lot of families where they're so busy that you can only get attention when there's a crisis, right? And these are not bad parents. These are not malicious parents. These are busy parents who have a lot of priorities, many of which are their children's well-being. But sometimes they're missing like what the child's wanting or needing, like kind of over prioritizing. I gotta save for college. I gotta pay the mortgage. But a lot of times they just want your attention.
Yeah. And they can only get it through crisis sometimes, and I see why it's happening. It's also like, because they could have a different dissociative disorder, or they could have higher levels of suggestibility, which now they really believe that they have DID. And like, there are people out there self-diagnosing with DID, which is just like, it doesn't make sense. Like, you can't diagnose your own time loss if you've lost the time.
Right. Oh yeah. I've had a lot of interesting interactions with people who are like, I remember all of these things that I forgot. I think I have dementia. And there's always like a really fun conversation to have. And then we'll do the objective testing and give some reassurance. But sure, maybe you don't have dementia, but there's something going on, right? So maybe it's not DID, maybe it's not dementia, maybe it's not ADHD, but there's certainly something treatable here. But the consent piece is huge. Like, can we agree to treat what's actually underneath these things that it's showing up as?
Yeah, I think consent is like the biggest thing.
Totally.
Period.
Absolutely.
And any treatment. That agreeing piece, because I've had to, because of my practice being so specialized in DID, the triangle area, essentially, even people from out of state, out of the country, they look to us to diagnose, assess DID. And what we've had an influx lately of definite malingering. And so like, there are certain tests for that, right? The SEERS, there's the MFAS, there's a lot of these tests that we do to kind of point this out of like, okay, there are some things going on here. However, if you look in terms of prognosis, or like, are they going to recover? Like, what are the rates of this? If they don't admit essentially like that they're purposely doing something, the rates are very low in terms of recovery and treatment. Like there's a lot of treatment failures over and over and over again. And then people become addicted to higher levels of care. And it's a very specific issue. And that is not my specialty. I do not specialize in treating that. I'm just like, do you have DID? Do you not have DID? Is it OSDD? Like what dissociative disorder or trauma is this? And then I can treat that dependent on like what they end up having with my specialty. Or if they don't, I usually send them out because this is not the place then. Okay. But if anyone wants to, treat malingering and specify, like, it would be helpful for the area to have. Just, I don't know anyone that specializes in it.
In malingering?
Yeah.
Uh-huh.
I can't.
It's a tough one.
Yeah. It is tough, yeah. Definitely a conversation to be had. I know that McLean is really great about that. It's a Harvard-affiliated hospital. Yeah. Yeah, it's just like we don't have McLean here. Right. But yeah, consent I think is a huge piece in any kind of recovery where I think the clinician is coming up to the clients being like, well, we have to integrate, we have to fuse. And it's like, if you don't have consent, like in the support group I run, about half, let's say, maybe a little less than half, but about half or so are deciding towards like healthy multiplicity, it's called, which is just kind of like, nope, we don't want to integrate, like horrible things happened, and let's just function in this life. We want to have a job, we want to have a home, and these are our goals, and we don't want to go beyond that. And it's like, okay, like I think about 65% of the clients I have without DID or dissociative disorders, people come in for depression. They're like, I want to get out of bed. I want to do what I used to do. It's not that we always heal from like the underlying. They heal as much as they want to. And they're like, yeah, I'm good for right now. And I'll come back in a couple of years or something, like. Yeah. And it's like, okay, like that's consent. They're saying, I want this much. Cool.
Right. Yeah.
Right. Got to meet them where they're at, right?
Yeah.
Yeah.
So if you're, I know we're short on time, but if you were talking to someone who feels a lot of gratitude about their progress, and they're about to say, I think we can meet less frequently, or maybe we don't need to meet anymore, and they were to say, here's how I felt when I started, and here's how I'm doing now. I'm curious, what might they say?
So all right, so I'm talking specifically with dissociative disorders in this one. Okay. Because I was like, well, that's big. I mean, it depends on what you're treating. But okay, with dissociative disorders, a lot of times they're like, I feel more grounded. I feel more present with my family. I feel more here. Or like a lot of times it's bringing that stability factor in. Like, okay, well, now you have a job. Or now maybe they don't have a job, but now they have friends and they never had friends before. And they feel more grounded and able to pay their bills and go to their doctor's appointments. And they're like, yeah, this is enough. And it's like, okay, like if this is what is enough for you, like who am I to judge that? Like you're the expert of you. And this is your life, your treatment. And like, all right. But sometimes they'll also say things like, oh, it depends like if they've done integration or not, right? Like sometimes they'll be like, I feel like a more whole version of myself. And that's huge.
That's huge.
And sometimes it's like very scary. So sometimes they do want to take treatment breaks of like, I just need to like do nothing for the next 3 months and just go to work, pay bills, like just live like a very normal, stereotypical, go get the groceries, like, okay, sure. Like the door's open if you want to come back. But that's some of the things that they might say. Usually it's about being grounded and remembering and just participating in life instead of just a lot of people have this like observation or this observer kind of effect. And then it's like, oh, I feel like I'm here in my body. Oh, look, I can look at my son and like I actually feel the joy in my chest instead of just like in my eyes or smile, or it's like, okay, it's a more full embodied experience.
That's awesome.
Even if they still do have like neural networks that are split. All right.
It's progress, right? So, maybe in closing, if there's a family member of someone that maybe they're concerned that may be struggling with this or knows that they're struggling with trauma, or maybe there's an individual that's listening to this that is relating to some of this and saying like, oh, maybe this is what's going on with me. What would be kind of like a advice or first step that you would encourage someone to take?
Advice one, stay off the internet.
Okay, there you go.
Advice two, seek a trauma specialist, specifically a trauma specialist. And they don't have to be a specialist even in dissociative disorders, honestly. Like anyone that really treats trauma and like that's their focus, they understand that there are different parts. They know what they're looking for, and if it's something they haven't seen before, a lot of times I'll have, people in the community, therapists in the community be like, hey, can I have a consultation? Like something's going on. So even if you can't find a dissociative disorder specialist in your area, which you might not be able to, that's okay. Like seek out a trauma specialist, specifically a therapist. That's in terms of family members, like kudos to you if you're listening to this as a family member, right? Like, and there are support. I think New Waters has support for families, right?
We sure do.
Every Wednesday night.
That's right. From 6 to 7.
Look at that.
I mean, it's an amazing resource, honestly. So I think it's a real gift to the community, and all are welcome.
Yeah, absolutely.
And NC Cutting Edge Counseling.
That's right.
Oh, yeah.
Yeah.
Definitely. We have support groups. I do a lot of research, and I have a research team, and we're creating new treatments for group therapy specifically for DID.
Okay.
And then my business partner is working on new treatments for BPD, borderline personality disorder.
Very cool.
Yeah. So
How many clinicians do you have in your practice?
we just hired some. Somewhere
Not
between
divisions,
8 to 10-ish.
That's great.
And we're hiring more. We have to turn away work a lot, actually. So we're still hiring for trauma specialists specifically, or anyone interested in trauma, treating trauma. But
That's great.
yeah.
In network, out of network.
Oh, Blue Cross Blue Shield and network all the way.
Okay.
Oh, nice.
Good.
Yeah. Blue Cross Blue Shield in this area is huge.
Yeah, absolutely.
Yeah. So definitely Blue Cross, or we have self-pay,
Okay.
but definitely, check us out if you feel like you want an assessment. I do assessments even if I can't. Usually my caseload is full. But I do assessments and send people back to their primary therapist and then talk to the therapist and like, hey, this is what this, and this test has said and stated, and this is likely what's happening. And we can tailor a treatment plan, even if they don't work with me. Also, Natalie Strzok also is specializing in dissociative disorders as well. So like the personality disorders / DID kind of crossover.
Okay.
If you look us up, just be like, hey, I need an assessment. Cool.
Yeah.
We do this all the time.
That's awesome. Well, Erin, thank you. Really appreciate you coming to hang out with us today.
Thanks for having me in this
Thanks,
cool
Erin.
studio. Yeah.
Yeah.
Thank you. And Dr. Hong, always pleasure.
Always. Yeah. Thank you, Erin.
Yeah.
So glad to have met you. And
Absolutely.
I think this is so important what we're talking about here. And I hope that people are plugging in.
Yeah, I appreciate the lens y'all are taking towards trauma and treatment and recovery in general.
Absolutely.
It's needed, that holistic version.
Yeah.
Yeah.
It is. Very passionate about that. And I feel like we just see that more and more with people, right? I think it's so easy to focus on the current presentation or the current set of problems that someone is struggling with. But, if we can just kind of pause a little bit, look a little bit deeper, I think that there's just so much commonality with a lot of things being driven by trauma or just a deeper place in general, right?
Oh, yeah.
Yeah.
Yeah. I mean, one thing I love about this place is I think there are certain therapists who are cut from like different cloths. And like, so once you have that trauma, like perspective, like once that's gotten into like how you see and hear and forming the treatment plan, you cannot unsee it.
Right.
Right. Like there's something about the way you experience where it'll always be different now. And then it's real interesting when you're working alongside a therapist who doesn't see it.
Right.
We've all been there.
Yes.
Yeah.
Right? and it's it's like you feel yourself like containing like something that really wants to get out.
Right.
And it's not the best feeling, to be honest, but when you're working with other people who see it, it's very exciting.
Yeah.
Right.
It's like the energy.
Yeah.
Yeah.
Right.
Absolutely.
And that's definitely the lens that we're bringing here, because like there's another therapist Paige, and she shared this thought that where there's addiction, there's trauma.
Yeah.
Absolutely.
Because like the addiction is a way of, in a lot of ways, it's a way of disconnecting from reality, which has a lot of overlap with dissociating, because they are trying to medicate the severe pain of ordinary living that's happened in their daily life. Yeah. And I can't blame them for that. Yeah. But we're here to help them find like new ways to deal with that pain in a way that's peaceful, sustainable, healthy, creates connection. And it's terrifying to people though, because they're thinking like, what the heck are you talking about?
Yeah.
Right?
Yeah.
But if no one can see it and at least like bring them to a vista point to look at what's possible, I don't know if they're going to find it. Right. And so this is like a huge like step forward in getting people to where they actually want to be, much faster, much safer. So that's why I love being here.
There you go.
Yeah, that trauma lens is so important. Once you have, like you said, it's like you see the world through that lens almost. And I think it provides so much more compassion for humanity.
I agree.
Yeah.
Completely.
Yeah. And we do a lot to destigmatize trauma and say, like trauma is something that gave you a dysfunctional set of rules for how you experience yourself, how you experience the world around you. And, it could be something, violently criminal that happened to you, like, God forbid. But it could be something as seemingly non-traumatic as like an over-involved, over-supportive parent.
Right.
Mm-hmm. Yeah.
And an over-involved, over-supportive parent, like many of us have been there, and we know how annoying it is. And right? And it created a lot of pain, like, because it's a form of control.
Right.
Right. And being controlled by another human is unsafe, and danger creates tension and stress. And that is pain.
Yeah.
Right.
Yeah.
So there's like a direct line from that to drinking, to self-medicating this pain. And I think it only helps our patients to be just realistic about that.
Mm-hmm.
Right.
I agree completely. Yeah.
Thank you, Erin.
Yeah. Thanks for having me.
Thanks, Erin.
Thanks for coming.